The third year that we've done this conference. This is the first time we've done it on a Saturday, so hopefully it's a little more convenient. One of the problems we had the last 2 years is people starving themselves all day to get their cholesterols checked. So we thought if we went earlier in the day, we wouldn't have folks fainting during the presentations. And so hopefully things have worked smoothly. People have gotten their blood work done if they want to. They've been to the different stations, and we'll be doing that again for a couple more hours. What we thought we would do for the didactic portion today is 3 different presentations from cardiologists. I will start and talk about heart disease and coronary artery disease in general, risk factors for heart disease, how we diagnose heart disease, how we treat heart disease. And then I thought I'd do a bit of a special focus on exercise and the heart and the benefits of exercise. I know we already have one presentation on that. And we've got lots of representatives from the summit that do a fantastic job of helping our employees, our community members, and our patients with exercise programs for cardiovascular fitness. So that's what I'm going to talk about. Then we have Rob Mitchell, who is one of our cardiologists, is going to talk about nutrition and diet in the heart. And Rob's not here yet, so I'll go ahead and say this since he's not here because he doesn't like me to do this. But before Rob went to medical school, he had a couple of different careers. First, he was a professional tennis player and actually played in the U.S. Open with his sister in the doubles tennis a few years ago. So Rob knows a little bit about exercise in the heart. But then he also went to cooking school and was a professional chef. And I think he's going to talk a little bit about cooking and cardiovascular health. And I can tell you I've eaten at his house several times, and I know no better cook than Rob. So I think he's going to do a little demo this morning, too. And then Eve Gillespie is going to talk about heart failure. Eve moved here from the East Coast about 6 or 7 years ago. And I guess I'll tell a little bit something about Eve as well. In 1977 or 78, she was the high school rodeo champion from New Jersey. I grew up in New Jersey. I didn't even know we had high school rodeo champions. So she's a little bit better fit in Montana than in New Jersey. Most of the people that did rodeo in New Jersey in my high school did it with Trans Ams and Corvettes and not with horses. But she runs our heart failure clinic, and she's going to talk to you about what congestive heart failure is, because there's often confusion about some of the terminologies we have with heart disease. What is a heart attack? What is heart failure? They're not necessarily the same thing. And she's going to talk about what heart failure is, and both lifestyle and medication and even device therapies that we have to treat congestive heart failure. And then that'll conclude the day. So hopefully it'll be educational and informative and a little bit entertaining. So I'm going to talk about exercise in the heart. But before I talk about exercise in the heart, I want to talk a little bit about the heart and a little bit about heart disease. And in particular, my most prominent area of interest is coronary artery disease, or atherosclerosis. So that's what I'm going to talk about. Now, the heart, as you know, is a pump. It's actually 2 pumps. The right side of the heart receives blood that returns from the veins that is deprived of oxygen and pumps that blood to the lungs. So you have a right atrium, which is a collecting chamber for the heart, and then a right ventricle that pumps blood to the lungs where it gets re-oxygenated. The blood that is then rich in oxygen returns to the left side of the heart, which is the second pump. The left atrium receives the blood, and the left ventricle pumps the blood through the aorta and supplies oxygen to the rest of the body. So when we think of the heart as a pump, really it's 2 pumps that work in series with one another. The right heart pumping oxygen poor blood to the lungs, the left heart pumping oxygen rich blood to the body. Now, the heart cannot derive oxygen or nutrients from the blood that's flowing through it. Alligators and certain other reptiles can, but not humans. We actually, about 15 years ago, in folks with really bad coronary disease, we took that model of the alligator heart and actually tried to use that, and we would take lasers and either in the operating room make dozens of little holes in the heart muscle from the outside, or in the cath lab make dozens of little holes in the heart from the inside to try to allow blood to seep into the heart muscle from the inside out. And it turns out it didn't really work that well. That was a model based on the alligator heart. The human heart can really only derive blood from the coronary arteries that run down the outside of the heart and allow the muscle of the heart to receive oxygen. So when those arteries become blocked, even though the heart is pumping 5 liters per minute to the body, the only way that the heart itself can get oxygen and nutrients is through the coronary arteries. And this is what a coronary artery looks like. This is obviously magnified when it's cut open. And this is the inside of an artery of someone with atherosclerosis. And all of this yellow debris in here is plaque. None of this should be there. And this is what coronary artery disease looks like to a pathologist. The reason we're talking about this today is that this is the #1 killer in our country, atherosclerosis. And it's becoming more and more of a problem. There was a study done during the Korean War where young soldiers who died in combat had autopsies. And about 10% of them were already, who were in their 18, 19, early 20s, already had evidence of this going on. The modern day equivalent of that was done in Detroit, another battle zone, where young victims of urban violence underwent autopsy. And as many as 20% of young men in their early 20s are starting to show signs of atherosclerosis. And in fact, we're even starting to see it in kids as young as 5, 6, 7 years old. There was another study done at Cleveland Clinic where they took donors who died in motor vehicle accidents or had head trauma, and they were heart donors. And we looked at their coronaries very closely, and as many as 20% you could start to see the beginnings of plaque. So it's not just a problem that occurs, after the age of 50. If we're going to make inroads on preventing this, we really need to start with our kindergartners. Well, this is what I was showing you earlier. This is the coronary artery sitting on the outside of the heart. And these arteries then give different branches that supply blood to the heart. There are 2 coronaries that supply blood to the heart. There's the right coronary that comes off this side. This is as if I'm facing you. And there's the left coronary that comes off this side. Now, some of you are going to say, wait a minute, I thought there were 3 coronary arteries. Well, the left artery almost immediately branches into an artery that goes down to the front of the heart called the LAD, that stands for left anterior descending, and then another artery called the circumflex artery that wraps around the back of the heart. So we talk about 3 arteries. In fact, there really are only 2. Well, then you think, well, wait a minute. My brother had a 5-way bypass. How can you have a 5-way bypass if there are only 3 arteries? Well, you can see that each of these arteries comes down. This one, for instance, comes down and gives a branch here, a branch here, a branch here. If you had a blockage up here and another blockage here and a surgeon was doing bypass, you might get separate bypasses to here, and to here. And so one artery could actually receive 3 bypasses. And so the bypasses refer to how many different branches need to be fixed. But there really are 2 arteries that supply blood to the heart, the right and the left. The left has a front and a back. And what we're showing here is what I showed you on the previous slide, which is plaque in the artery. This is filleted open. And if the plaque narrows the artery and one does not get enough blood flow through that artery, then the heart will send you a signal. It'll send you a signal of pain or pressure or burning or tightness. That's what we call angina. If the narrowing in the artery becomes unstable, and we'll talk a little bit about how that happens and how we can prevent that, a blood clot can form, and now there's no flow getting through there whatsoever. That's a heart attack. And what's shown here, this pale purplish area here, is downstream from where the total blockage occurs. And within about 4 hours, if we do not restore blood flow to that area, that heart muscle will die. It will turn to scar. And so that's what a heart attack is. And I've had numerous patients who have come in. Oftentimes when someone has a heart attack, they have the sudden onset of chest symptoms. If you really go back and talk to them, in many of those patients, there were some warnings. They'll say, well, yeah, for the last few days I was getting a little heartburn. I didn't really know what it was. I thought maybe I was getting the flu or I'd eaten something bad. That was their angina. I saw a fellow who wanted to have his knee replaced. This is when I was still in Seattle. He was a Boeing engineer, we have any Boeing engineers in the audience? They're a different breed. If I had a Boeing engineer walk into my office, I didn't do a stress test. I knew he had coronary disease. In Seattle, that's the #1 risk factor. And this fellow wanted his knee replaced, and they did an EKG. You know, the anesthesiologist did. And he said, "You've had a big heart attack." I said, "I've never had a heart attack. That can't be." And so they sent him to see me, and sure enough, he'd had a big heart attack. And I said, "You'd never had chest pain?" He said, "No." I said, "You never had bad heartburn or indigestion?" And he said, "No." Fortunately, his wife was there, and she said, "Come on, honey, tell him about New Zealand." And I said, "What happened in New Zealand?" He goes, "Well, we were on vacation last year, and I had the worst heartburn of my life. It lasted for 24 hours. I couldn't get out of bed." Well, that was his heart attack. And so my point is that oftentimes when you have a sudden closure of an artery causing a heart attack, there were some symptoms beforehand that maybe were a warning sign. And, you know, we don't always recognize the warning signs. Once that artery closes, we've got about 4 to 6 hours to get it open if we're going to save the heart muscle. And I'll talk about strategies we have here in the Valley for doing that. Now, in some patients, truly the blockage was pretty minor until the lining became somewhat roughed up and undergoes a process we call plaque rupture. And I have had patients who had stress tests with me a week before their heart attack, and they were normal. You could not detect any limitation in blood flow. But then if something happens to that plaque to attract a clot to form, you can go from a patient who can pass a stress test, run a 10K, feel perfectly fine, to suddenly having a heart attack. And that's why some of the programs like this are important, to get out awareness in the community. If you are one of those people, what do you do? As I mentioned, cardiovascular disease is the leading cause of death in this country. Many people don't realize that more women die each year from heart disease than men. And many people, I said this last year, don't realize that more women die from heart disease than from all forms of cancer combined. 10 times as many women die from heart disease as from breast cancer. And so it's not a disease limited to men by any means. We'll talk a little bit about the risk factors, and that's what all these stations are about today. And I like to talk about the modifiable and the non-modifiable risk factors. Modifiable risk factors are things you can do something about. And some of the risk factors we show here, like smoking, high blood pressure. This is someone getting their finger poked to check their cholesterol or to check for diabetes, diet. These are all things that can put you at risk that you can do something about. Some of the non-modifiable risk factors would be things like your age, your gender, your family history. And so it's important to know what these risk factors are and know which ones you can do something about. I like this slide. This is a good one for other risk factors. This is usually me on a Sunday afternoon after I've been on call. That would be a pillow under my T-shirt. I don't quite look like that. As you might guess, I do exercise. I was a bit of an athlete in college, and fortunately the summit has allowed me to continue to do that. And I'm there usually 6 days a week, sometimes 7, and I see many of you there. And I think it's kind of helped me stay fit. In fact, I had a new patient last week. It was kind of funny. She came to see me, and she said, "You're my cardiologist?" And I said, "Yeah." And she said, "You're old enough to be a cardiologist?" And I said, "I graduated from medical school 27 years ago. I'm old enough to be your retired cardiologist." And I think most of that's genetics, but I think part of that is exercise. And so sedentary lifestyle, and that's what I'm going to talk about today, is what's the data? What's the information? I mean, it makes intuitive sense. Everybody knows exercise is good for you. But do we really have data that it works? A couple people today asked me about a study that apparently was in the news this week that I haven't seen yet about aspirin and macular degeneration. And it said, gee, aspirin might cause macular degeneration. Well, in this information era that we live in, you can go on the internet and really find anything you want. And my job is to kind of sort through, what has good data, what has good proof, what's real, and what isn't. Next year I'll talk about macular degeneration and aspirin because I haven't seen the study yet. But what I'm going to do is talk a little bit about the studies that we've done that demonstrate that exercise is beneficial in preventing heart disease and in and in helping you if you already have heart disease. Other things, unhealthy diet, Dr. Mitchell is going to talk about. And again, I'll kind of expose him a little bit. I have eaten at his house before where I know what I ate was not heart healthy, but most of what he does is. He can do things with butter and salt that most people can't. And then a couple other things that we really focus on in cardiac rehab are stress and the so-called type A personality. Again, having come from Seattle, my practice was located about midway between Boeing and Microsoft, which is really type A heaven. And, you know, type A is how things get done. But it also, when it's taken to an extreme, we know that stress can also contribute to heart attacks. There's been a couple of studies about that. I'll just diverge for a minute, that looked at stress and heart disease. And there are two things that are very interesting there. I moved to San Francisco to do my cardiology fellowship in 1989 and had never lived on the West Coast. I'm, as I mentioned, an East Coast boy. And, you know, we moved to San Francisco, an exciting city. We lived in the Marina, which was kind of the yuppie area. And 3 months after we got there was the Loma Prieta earthquake. And you know, I thought, what have I done here? I mean, our building was destroyed. We had to move out. It was really kind of a traumatic experience. And a fellow in Los Angeles who then lived through the Northridge earthquake a few years later decided to study that and say, what does this do to people with heart disease? And so he looked at the Northridge earthquake in Los Angeles, and he looked at the Kobe earthquake in Japan, and looked at rates of heart attack the week after the earthquake and compared them to the same week a year before. And they were up almost 20%. You may have read that a fellow was just, I don't know if he was charged or convicted with first-degree homicide, a fellow who set a fire intentionally in Southern California a few years ago. And 5 people fleeing the fire died of heart attacks. And so that arsonist is now being charged with their murder because the stress caused the heart attack. And so there's good data to show that that's the case. We have a syndrome that we've now recognized in the last 10 years that's called stress cardiomyopathy, where we will see, and this happens much more commonly in women, we're not sure why, but we will see women come into the emergency room with chest pain, with EKG changes, with blood enzyme changes, with the whole front wall of their heart not moving. Everything about it looks like a heart attack. We rush them off to the cath lab, we do an angiogram, and their arteries are clean as a whistle. They're wide open. And you go back and talk and say, well, what happened before the heart attack? And usually there's some very acutely stressful situation. And something about that will trigger a heart attack that has all of the hallmarks of a heart attack, except that the coronary artery is wide open. Now, the good news about those heart attacks is usually people don't have fibrillation and drop dead from them, and that's the biggest risk of heart attacks. And usually the damage completely reverses. And it's something we're still trying to understand. This, you know, I've seen this for about the last 15 years, but the first group that described it was in Japan. And when they looked at the hearts, there's a characteristic appearance of the pumping chamber of the heart, the part that doesn't move. And the first fellow that described this from Japan thought it looked like these old ceramic squid traps that fishermen in Japan used to fish with. That was the shape of the heart. And the Japanese term for squid trap is takosubo. And so this is also known as takosubo syndrome. But it's basically a heart attack that's triggered by stress that has all the hallmarks, all the appearance of a heart attack, except the artery does not look like this. The artery is completely clean. So we're really beginning to appreciate that stress can trigger standard heart attacks in people with plaque in their arteries, and it can even trigger heart attacks in people with clean arteries. So basically just nobody have stress in their life, and that'll take care of it. And if that's a problem, I can write a prescription for you afterwards. As I mentioned, the most devastating consequence of coronary disease, of atherosclerosis, is the heart attack. And you know, we still see about 20% of heart attacks, maybe 30% don't have preceding symptoms. Again, I think if you really look carefully, you find symptoms more often than not. But we also still see people presenting with their first symptom being sudden death. The heart artery, the coronary artery occludes. And even before someone has time to complain of chest burning or chest pain, the muscle that's not getting oxygen does not like that and can go into a chaotic electrical rhythm that can spread to the rest of the heart, and folks die suddenly. And we still see, and it's a little more common in women than men, that'll be the presenting symptom. And if you are not in an area where the cardiac collapse is witnessed, and if you don't get immediate CPR, and if you don't happen to have a defibrillator around, and I know we have one in this building, then the likelihood of surviving that is very, very, very low. There was a study done a few years ago that looked at sudden cardiac death and survival rates. And they actually looked at different scenarios where people might drop dead. And they said, if you were to have a fibrillation arrest, and you were in the intensive care unit of Kalispell Regional Medical Center, or if you were on the Delta flight to Salt Lake City, or if you were in the mall in Missoula, or if you were in the Bellagio Casino in Las Vegas, which one of those 4 cardiac arrest patients would be most likely to survive? Anyone want to hazard a guess? Bellagio, right. And the reason for that, you think, well, gosh, if you're in the ICU and you got a nurse right there and a defibrillator right there, why wouldn't you be most likely to survive that? It's because you're already sick. You're already in the ICU. And the reason the folks in Bellagio survive is they've got the entire place under constant surveillance. They have security who are trained to use defibrillators, and they have defibrillators. So the message here is, if you're going to have a cardiac arrest, go to Bellagio, blow all your money, arrest, and then you'll survive. But this is what we're trying to prevent, because unfortunately, even with security cameras, defibrillators, and people trained in CPR, most folks who have a cardiac arrest outside the hospital do not survive. So the key is to prevent it altogether. Now, I talked about the typical symptoms of heart disease, the burning, the pressure in the chest. You know, when I see a patient come into my office and they say, yeah, my primary care doc wanted me to see you because I'm having chest pain. Describe the chest pain to me. Well, it's like a knife. It's like a needle. You know, I kind of turn off when I hear that. That's rarely coronary symptoms. The more typical description is it's a heaviness, a pressure, a burning. Feels like an elephant on my chest. Feels like a rope wrapped around my chest. Those symptoms to me are much more concerning, much more typical of heart disease. Usually it can radiate up to the jaw or down the left arm. Occasionally the right arm, but usually the left. Those are the typical symptoms. There can be less typical symptoms. You can have jaw pain without the chest pain. You can have back pain. You can have palpitations, just an erratic sensation of the heartbeat. Other symptoms include things as vague as dizziness, weakness, nausea, or even abdominal pain. And so it's important to not only know the classic symptoms of heart disease, but to also know that, hey, this is something that I've never felt before. It doesn't seem right. You know, that could be coronary disease as well. And we know that in women, these atypical symptoms are a little bit more common than in men. So if I see a woman who has risk factors for heart disease and says, you know, I'm really just having nausea or shortness of breath or I'm weak, I pay a little more attention to that. Diabetics, particularly diabetics that are on insulin, may also have atypical symptoms. And diabetics, because they've got changes in their sensory nerves, may have heart attacks and not feel it at all. Truly silent heart attacks. And so that's important that we keep in mind the atypical symptoms of heart disease. Well, what do we do if we think that someone has coronary disease? If someone is having symptoms at rest, if we're worried that they're in the throes of having a heart attack or about to have a heart attack, we still use the good old-fashioned EKG. And there are typical changes that we can see on an electrocardiogram. The key here is that the electrocardiogram will only show us a problem if someone is experiencing their symptoms at the time of the electrocardiogram, or if they've already had damage to their heart. I can't tell you how many folks I've seen in the emergency room, they're having a heart attack or unstable angina, and they say, yeah, but my family practice doc did an EKG 2 weeks ago and it was fine. Well, you weren't having symptoms 2 weeks ago, and the EKG wouldn't show us it. It wouldn't show us a problem unless you were having the symptoms at the time. But that's a good first step, and that's, in my office or in the emergency department, that'll be the first thing that we do. If someone is having symptoms that sound like angina, so they're having symptoms when they exert themselves but not at rest, well, then an EKG at rest would be fine. So what we do is try to recreate the scene of the crime. We try to say, all right, if you get symptoms when you're walking up an incline, let's have you walk up an incline and see what happens. And that's what a stress test is. And I've had numerous patients come into my office, and I say, well, let's do a stress test. And they say, well, I'm worried about doing a stress test. What if I drop dead? And I said, well, there's not a better place to drop dead. I'm not going to be much use to you, but I usually have a pretty good nurse with me. And in 25 years, I've had 2 patients actually have heart attacks on the treadmill. And I've probably done 4,000 or 5,000 treadmills in that time. And both of those patients did fine. And my point is, if walking on my treadmill is going to cause a heart attack, hiking in Glacier is going to cause a heart attack, and this is a better place to have it happen. So, we start the treadmill very gradually, and you usually have 2 or 3 people in the room with you, and it's generally a safe thing to do. And if it's not a safe thing to do, that's all the more reason to do it. A lot of folks that we suspect heart disease can't walk on a treadmill. They might have emphysema, a previous stroke, a bad knee, a bad hip. And so we have ways of simulating exercise. We can actually put an IV in. How many people have had a pharmacologic stress test? And so we can do that. And no, you can't do the simulated exercise instead of exercising. I had one fellow say, hey, can I just hook up to this 3 times a week? And that doesn't work. But we can increase blood flow through the coronary arteries with a medication and simulate exercise and accomplish the same thing as a treadmill test. Now, I'll be honest with you, I'm a little bit biased. If I've got a healthy 55-year-old with no other problems who can walk on a treadmill, I will have that person walk on the treadmill. I think I learn a little bit more with the real exercise stress test than with the simulated. But if the simulated stress test is the only way we can do it, that's a good alternative. And so what we do when we have someone walk on the treadmill is I like to watch them. I like to see what they look like. I would say 90% of the time I can tell if someone is likely to have heart disease, atherosclerosis, just by taking their history and seeing how they look walking on the treadmill. I can do a lot more sophisticated and expensive imaging, and we often do. But it's amazing, just with a careful history and observing someone during exercise, you can have a pretty good sense of who has heart problems if you've done this for a while. But not everybody. So we have additional things that we look at. This is an ultrasound probe. Ultrasound is a non-invasive way to look at the heart. It uses sound waves. Many of you have probably had echocardiograms or ultrasounds. Those are synonymous terms. And what we do with the ultrasound, we don't see the arteries. We don't see the blood flow. But what we see is the muscle contracting. And so if someone has a healthy heart, we'll look at all the walls of the heart, and they'll be contracting very nicely. And when we have you walk on the treadmill and get up to a good clip, get your heart rate to 140, all those walls will contract more vigorously. If you have a significantly blocked artery, that wall will look good at rest. You're getting enough blood flow. You can have a 90% blockage, 95% blockage, and still have enough blood flow getting to the muscle that will contract normally at rest. But as soon as we make that muscle work harder by having you exercise, it's not going to get enough blood flow. And let's say this wall has a blocked artery. After exercise, we'll take pictures immediately, and we'll see that wall just freeze up. And then with time, it'll come back. So that's what we're looking at on the echo. We're looking at wall motion to see if the wall motion is normal at rest, but with increase in heart rate and blood pressure and increased oxygen demand on the heart muscle, if you have a narrowed artery, it's going to give up. It's going to say, I can't do this, and stop contracting temporarily, and that's what we're looking for. And so the stress test with ultrasound is a little bit challenging because we get you going, real good on the treadmill, get your heart rate up to 150, you're short of breath, and then lay down, stop breathing. Laying down's not hard, but getting people to stop breathing after you've had them run for 9 minutes can be a challenge. But that's how we do the ultrasound test. Not everyone images well. If someone has emphysema, and they have really hyperinflated lungs, sound waves don't transmit through air very well. Sound waves actually transmit through fat really well. In fact, real thin patients are sometimes hard to image. Women that have had mastectomies are hard to image because breast tissue or fat is a beautiful medium for transmitting sound waves. And so not everyone gives us good pictures. When I was in Bellevue, my wife thought that our blue healer had heart failure because she was panting a lot. And so she wanted me to do an ultrasound on the blue healer. Does anyone here have a blue healer? Yeah, I mean, just amazingly smart dogs, but they're challenging because of that. So we snuck the blue healer up to my office, and my sonographer was game for it, and we're trying to get pictures of her heart, and she's panting because she's excited and can't see the heart because of the lungs, because she's breathing. And so, you know, I said, Belle, that was her name. I said, Belle, stop breathing. And I swear to God, I was there. She stopped breathing, and we got beautiful pictures. She held her breath, and we got good pictures. And they're smart dogs. I can't get my patients sometimes to do that. It was a little easier to get the dog, and she didn't have heart failure. So the point is that not everyone is as smart or as imageable as a blue healer, and so we have to have alternatives. And we do. We have CAT scans, we have nuclear cameras, and we have PET scans. And this could be any one of those three. They all kind of look the same. And the strategy there is that you're not so much looking at the motion of the heart muscle, you're actually looking at the blood flow to the heart muscle. And so with a nuclear scan, for instance, what we will do is put an IV in, and we'll take a substance called an isotope. It emits gamma rays, which are like X-rays. So it's basically an X-ray from the inside out. And we use a gamma emitter called technetium, and that's the radioactive substance that emits the gamma rays, and we'll link it to a chemical that is very specifically taken up by heart muscle. And so if we inject it into an IV, it'll circulate to the heart, it'll give off the gamma rays, and it'll give us a nice picture of the blood flow to the heart muscle. If you've had a heart attack and part of your heart muscle has turned to scar, then we will see no gamma rays from that part of your heart. It'll come up as a negative image. If you have a narrowed artery that hasn't been damaged yet, then at rest, blood flow will get to that part of the heart, and we'll see gamma rays emitted, and it'll look normal. But as soon as, again, we put that heart under stress conditions, either with a drug or with exercise, and you're not getting enough blood flow to that part of the heart, then we'll see that as a negative image. So again, it requires before and after imaging. But with the gamma emitters, we don't have to have you stop and hold your breath and get pictures right away. So in a way, it's a little easier test for a patient, because we can have you walk on the treadmill and then kind of take our time getting the pictures afterwards. But that's the strategy. And at a Kalispell, we primarily use gamma ray technology, the nuclear camera, but you can use CAT scans, you can use MRI, you can use PET scans. And in fact, you guys have probably seen our mobile gamma camera lab. Is anyone at the Whitefish Winter Carnival Parade? No Whitefishers here? A couple? Yeah, so our gamma camera was actually in that parade. It was one of the, and it's nice because we take it to Libby, we take it to North Valley, we take it to Polson. You might have noticed I was also in the parade. I was driving my pickup truck, and it was the thrill of my life because I was dressed like a pirate. And as I went down Main Street, a group of 7th grade girls pointed to my pickup and said, "Look, it's Johnny Depp." And you know, I could now die and go to heaven after that. But we have the gamma camera, and we now take it around northwestern Montana to provide this service. So what if we find a blockage? What do we do about it? First thing we do is try to prevent the blockage, and we do that by addressing the risk factors. I had a patient in my office not too long ago. He had some chest pain. We did a stress test that looked abnormal. I did an angiogram to look at his arteries. And one of his arteries, about 2/3 of the way down, was blocked completely. But he didn't have a heart attack because his body had sensed what was going on and actually grown little collaterals, kind of like a plant sending out roots during times of drought. The heart will do this sometimes. And so he had given himself a bypass. Now, it's not as good as a surgical bypass, but it was enough to keep him from having a heart attack. He had some blockage in other spots, but none of it was real tight. He had some 30 and 40 and 50% narrowings. And the guy was kind of a mess. You know, he was a smoker, diabetic, high blood pressure, high cholesterol, bad diet, no exercise. So I said, here's what we're going to do. We're going to get you to exercise, improve your diet, quit smoking, put you on an aspirin as a blood thinner. I'm going to treat your high blood pressure, I'm going to treat your diabetes, and I'm going to treat your cholesterol. And his wife said, "Are you going to put in a stent?" I said, no. And she goes, you mean we're not going to do anything? And I said, no, we're going to do those 7 things that I talked about. If you have a tight blockage that needs to be opened up, that's then when we can do an angiogram, where we'll run a catheter in from one of your peripheral arteries, inject dye or contrast into the coronary arteries and see what they look like. Now, this is already a dated slide because these days probably 70% of the angiograms I do, I don't go in the groin anymore. We go in the wrist. Do you have any members of the wrist club in here? Okay, so at least one. I was on the fundraising train going from Whitefish to East Glacier for the Glacier Fund this summer. And, you know, it's real nice. They get the Burlington Northern, the real nice VIP car for the people that are going to the dinner. And at one point, I think there were 5 people in that car, and we were all just, you know, having the hors d'oeuvres and a drink. And they all had angiograms that I had done from their wrist. And so they called themselves the Wrist Club. They were all comparing scars. And one of the fellows in the group said, boy, I'm sure glad you don't use the groin anymore. This would be kind of inappropriate. But the point is we can now, in many people, actually go in from the wrist, which is a lot easier for folks. The recovery is quicker. The bleeding is less. But the point is we go in from an artery, inject dye into the coronaries, and see what they look like. And if we find a blockage, you know, we can treat it. Well, let me get to that in a minute. But that's how we would then definitively tell you that you have coronary blockage. Now, we can do pretty good angiograms, and Dr. Mitchell does a lot of these in folks where you can see the coronaries pretty well using a CAT scan these days and just inject the dye into a vein. And so in folks where our suspicion is not real high, we might actually start with an angiogram done that way. The limitation of the CT directed angiogram is if we find a blockage, we're not there to do anything about it, and I'll talk about that. So what do we do if we find blockage? Well, again, heart disease treatment is multifactorial, and it's different for everybody. And as I mentioned with my patient that had all the risk factors, you know, I can put a stent in one spot in your artery, and I'm only treating that one spot. We really have to address all of the other risk factors: your diet, your exercise, your smoking, your blood pressure, your cholesterol, your diabetes. And so those are all components of lifestyle modification that we can do. Oftentimes that's not enough, and so we resort to medications. And we may have you on medications to lower your blood pressure, to improve your diabetes, to thin your blood like an aspirin or Plavix or Effient, these new blood thinners we have, and to modify your various cholesterol levels. These days, still the best cholesterol drugs we have are the statins for lowering your LDL, your bad cholesterol. Our strategies to raise the good cholesterol haven't been terribly successful, and even our strategies to lower triglycerides not as effective as statin therapy to lower your bad cholesterol, but that does work well. If that isn't sufficient, if we do all those things and you're still having symptoms and you still have a high-grade blockage, then we can go in the coronary and try to open up the blockage from the inside out. And this is a balloon being inflated at the area of a significant plaque and stretching the artery open. When I first started doing this in the late 80s, that's all we had. And you'd stretch an artery open with a balloon, and you'd just keep your fingers crossed and hope it stayed opened. And a lot of times the artery, you'd pull the balloon out and it'd just recoil. Or you'd crack the inside of the artery and make it unstable. These days, we routinely, 95% of the time, if we stretch an artery open with a balloon, we'll then go back and put a stent in, which is a metal strut that looks like kind of like the spring in a ballpoint pen that will then stay in place and hold the artery open. And those have become much more effective than just doing the balloon. And these days, when I put stents in, about 85% of the time I put stents in, we'll put in stents that are called drug-coated stents. The stent itself, as I mentioned, is a metal coil. They were originally made out of stainless steel. Now they're made out of chromium cobalt or chromium nickel, which is a more flexible and a kind of a more durable metal. But it's metal. It's in there. It's not going to dissolve. It's not going to go away. Once we put it in, we can't take it out. But it's also a traumatic event for an artery. It's like a shrapnel wound. And arteries are programmed to repair themselves when they're injured. And so what we found with stents is we could put them in, artery would look beautiful, send the patient home, and 6 months later they'd have their angina again. And we take a look, and the artery had re-narrowed, this time with scar tissue, because that's what arteries are programmed to do. If you cut an artery, it'll form scar. If you put a piece of metal in an artery at 230 pounds per square inch, which is about what we do, your automobile's tire is about 35 psi. We inflate these balloons to about 235 psi. So that's a little shrapnel wound. And so in some folks, the stent would re-narrow with scar tissue. What we now do is put in a stent that's coated with a medication. It's like a cancer drug, a chemotherapeutic drug, that prevents the scar tissue from growing. And they work quite well. In fact, we've gotten the re-stenosis rates down to about 5%. So if I put a stent in 20 people, 19 of them, I expect them to stay open long term. And then as a last resort, if we can't do a stent, but you need to be fixed, we still do bypass. In fact, Dr. Kirshner, one of our cardiac surgeons, was here last year, talked about bypass surgery. He's actually in Hawaii this week, so he couldn't be here today, poor guy. Bypass is also still a very viable alternative for people when they have lots of blockage that we can't fix with medication and lifestyle and stents. And so heart disease is modifiable. We can actually, with a combination of lifestyle changes and medications, even cause some reversal of heart disease. And we've got some new therapies for lowering LDL cholesterol that we've just started at Kalispell, therapies that are not yet FDA approved, experimental therapies, where we're getting people's LDL cholesterols below 30. In fact, we're a little worried about getting the cholesterols too low. But that's how we're going to reverse heart disease. Right now, we don't have strategies where we can melt plaque away, but I think we're getting closer to that. And so what I'd like to end up with is just a few slides that talk about exercise. I'm a big fan of exercise. I'm a big proponent of exercise. And I try to do what I preach. But what about the data? I mean, does exercise work in heart disease? Well, there's a couple different kinds of exercise. There's the isotonic exercises, which is the aerobic walking on the treadmill stuff. And there's the isometric exercise, which is the weightlifting kind of stuff. I think for cardiovascular health, we're talking more about the dynamic exercise, the aerobic exercise. We know that inadequate physical activity is recognized as a risk factor for heart disease. Physical inactivity in some studies led to at least a twofold increase in people developing heart disease. And so in the medical profession, we're proponents of heart disease. We know that heart disease improves your cardiovascular health and your overall general fitness and feeling of well-being. And it's also very helpful for folks that are struggling with weight control and diabetes and hypertension. When you look at exercise in the heart, there are two different groups of people that we talk about. When we talk about primary prevention, we're talking about people who have not yet had a heart attack or a stent or a bypass, and we're trying to prevent that from happening. And there have been a number of studies that show, again, an inverse relationship between exercise and the risk of heart disease. If you exercise, you're less likely to get it. If you don't, you're more likely. And most of these studies were done in men, but we're starting to see evidence in women as well. One of those studies was the Harvard Alumni Health Study. Now, I went to Yale, so I don't put much stock in Harvard studies, but I'll show this one anyway. And in this study, this was 10,000 Harvard alumni, and those alumni who reported moderate vigorous activity versus those who had no activity had a 23% lower risk of death. And so that's, again, a good kind of correlation for primary prevention. If you look at another study that was done, and this was in almost 10,000 people that were followed for 5 years, the age-adjusted all-cause death rate was approximately 3 times higher in men who were unfit. And what they did in this trial is they looked at you at the beginning of the trial, and they looked at you 5 years later. And you had 4 different groups: people who were unfit at the beginning and unfit at the end, people who were fit at the beginning and fit at the end, and then people who were unfit at the beginning but exercised and looked good at the end, and then the people who, for some reason, were fit and exercising at the beginning and then fell off the wagon. And when you take people who were unfit at the beginning and unfit at the end and compare them to those who were fit at the beginning and fit at the end, about a 3-fold higher rate of death in the unfit people. And people who went from unfit to fit did better their rate of death was only 68 for every 10,000 people years versus 122 in the unfit. So if you went into the study unfit and got religious about exercise, you improved your chances. That's primary prevention. I thought the most interesting study was done in Finland, where they took twins and they looked at 8,000 different sets of twins. And in those sets of twins, where one was an exerciser and the other was not, if you were an occasional exerciser, your odds ratio for death was 0.66. That means you had a 34% less chance of dying than if you were completely couch potato. Does anyone know how to say couch potato in Finnish? I should have learned that. If you were a vigorous exerciser, the death rates were actually half. So interesting, because there in twin studies, you're kind of getting the genetics out of the equation and just looking at the fitness. Now, what about women? I promised that we also would try to look at women. The Nurses' Health Study, which was also done through Harvard, has now followed over 70,000 women. And they found that in those women that did just exercise that was reported as brisk walking, or those who did vigorous exercise, were less likely to have a coronary event. So I think the same kind of benefit applies to women as well. And so the American Heart Association, based on studies like this, issued a science advisory that made physical activity as part of both our primary and secondary prevention. Actually, I heard something interesting yesterday. We've had two presidents and now a first lady who've been big proponents of physical exercise. The first was Teddy Roosevelt. And Teddy Roosevelt said that when he became president, that he thought that Marines should be able to walk 50 miles. So when John Kennedy, the other president who initiated the presidential physical fitness program, when he became president, he kind of jokingly said, well, I think my cabinet should all be able to walk 50 miles. And 50 years ago today, Bobby Kennedy walked 50 miles from Washington, D.C. to Camp David. I'd never heard that about him in 20-degree weather. And so these types of advisories have been around for a long time, in fact, going back 100 years with Teddy Roosevelt. And that's why it's become an important part of kind of our health policy, and I'm glad to see that the First Lady has really jumped on board with trying to get kids to take this up. What about secondary prevention? Secondary prevention refers to if you've already had a heart attack or a bypass or a stent. Can we reduce your risk of having a second event? That's where secondary prevention comes in. And again, there have been studies that looked at this. This was a relatively small study, about 700 men, and this was published now about 13 years ago, who had already had a coronary event, and half exercised and half didn't. And they found in this study that the lowest incidence of dying of a cardiovascular cause were in those who engaged in light and moderate activity. Now, keep in mind, this is light and moderate activity. This is not running a half marathon. And this is the kind of stuff that the folks at the summit will help you learn how to do. And when we have patients that have had heart attacks or had bypass surgery, we routinely refer them to our cardiac rehab secondary prevention trial at the summit. A meta-analysis is when you take a bunch of small studies that are similar in design and group them all together and try to learn something of statistical relevance. And this meta-analysis that's now quite old looked at 10 different trials of exercise in people that had survived a heart attack, and again found that there was a 25% reduction in cardiovascular events in folks who did exercise. And then finally, this was a national trial that's, again, a few years old now, but saw a reduction. It didn't reach statistical significance, but at least a trend towards a reduction in mortality in folks that had survived an initial heart attack and went into an exercise program. So, I think that sometimes cardiac rehab programs have been criticized as not having real good hard data, like, for instance, taking an aspirin does or taking a statin does. But I think there's pretty good data suggesting that exercise benefits folks from a primary prevention and a secondary prevention point of view. And what do you need to do? Not as much as you might think. I mean, 30 to 60 minutes of exercise 4 to 6 times a week. And this can be as simple as using the stairs and not the elevator, and vacuuming and gardening and doing things that you enjoy. It doesn't have to be the Stairmaster. And how should you gauge your exercise? Now, there are folks from the summit that might kind of differ in opinion from me on this, but I'm not a big fan of scrupulously monitoring your heart rate. I mean, we do that when we do treadmill tests, but I tell patients, especially if you're on a beta blocker, you're not going to get your heart rate up. Beta blockers, metoprolol, atenolol, they don't allow your heart rate to go up. And so I tell folks, I want you to exercise until you're sweaty and short of breath and tired. And if you're getting sweaty and short of breath and tired in 4 minutes, you're doing too much. Back off. If you do 20 to 30 minutes and you're not sweaty, short of breath and tired, do more. And I'm not, you know, I don't hone in on the heart rate as much as some people, but that's my own personal preference. And these can be for short periods. If you can't dedicate 30 minutes a day, do 3 10-minute periods, and you will still get cardiovascular benefit. And again, brisk walking can be enough. It doesn't have to be at a gym, although the Summit people would prefer you do it at the gym. Not really, actually. And again, I like to see a little bit of free weights as well, just for muscle tone. But here we're talking mostly about aerobic exercise, about the isotonic exercise, isometric exercise. And for secondary prevention, I think it's important that if you've had a heart attack, if you've had bypass, probably meet with your cardiologist or your internist or your exercise physiologist and set up more careful parameters